Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and my guest today is Rhonda Finnie. Welcome, Rhonda.
Thank you so much for having me.
Rhonda, thanks for appearing on the program. And today we're going to talk about something that's a little mysterious, I think, for a lot of physicians, certainly physicians my age, and that's the role of uh, non-physician providers. You know, we're all familiar with the RN, and when I grew up, there were nurses and there were doctors, but now there's this whole other category, sometimes referred to as mid-levels. And I don't know if that's a politically correct term or not. You can correct me. But there was an article published recently in JAMA Neurology by a nurse and by a physician about the role of nurse, let's call them advanced practice clinicians. I think that's the proper term, right? APN, advanced practice in neurology. I'm a neurologist and you work in neurology. So first, tell us what your training is and what you do in neurology, and then we'll get into the philosophy of the question.
Well, thanks for the opportunity. I have been in neurosurgery actually since 2004, and I spent about 2 years on the acute stroke side as well, in acute stroke treatment with the neurologists who are on staff at our facility. And so I've been an RN since 2000, and since 2002. I started in neurosurgery in 2004. I was always a big person who believed that certification was very important, and that was a way to standardize our education and our onboarding. And so I did that. I was a CNOR because I assisted in surgery. So I've seen a lot of traumatic brain injuries, spinal cord injuries, worked closely with neurology for many years. And one of my colleagues moved over from the neurosurgery practice and became the stroke nurse coordinator. And there was a role for an advanced practice clinician in that service. It really did help expedite the treatment of those patients. It really did help divide the work and provide a shared responsibility for those patients. And so I did
stroke
that.
patients.
For stroke patients, yes. Yeah, for acute stroke patients. I completed a fellowship in stroke through NetSmart because I knew that when I went to neurology, I did not have the needed skills and knowledge that I needed to really provide a good evidence base for my practice. I needed to be able to explain it, and I needed to understand it in order to apply it. And if you depend on on-the-job training, that can be very, very haphazard in some sense. You're very tied to the local practices. You may or may not be as tied to really where the evidence is in terms of how you're going to make decisions or how you're going to advocate for decisions. And so I completed that fellowship. I sat for the ANVP board exam, which is the Advanced Neurovascular Practitioner Board exam through the Association of Neurovascular Clinicians, and passed that exam. It was a challenging exam, I will tell you that. And so I was very proud to pass that. But my original population board certification is adult gerontology acute care. And I think that's where physicians get a little bit confused in terms of how we're boarded and what populations we can really take care of. I think that creates an initial confusion as well. But all the letters that you see behind my name are really my entire career and those letters. And so I'm also certified as an advanced stroke coordinator. I wanted to be able to help teach that class, and in order to help teach something, you need to be certified in it. And so I'm a really big proponent of postgraduate education. I think that really is the way that we can validate knowledge, and we need organizations that can help us do that. And ANVC is one of those.
Well, certainly, and this was the thrust of the article, there are not enough neurologists to care for all the people who need neurology care. And this situation is only going to get worse, and probably is worse as of today with the new approval for the Alzheimer drug. A lot of people who are staying at home, well, I have Alzheimer's, nothing really can do about it. Now it's like, well, either they or their family is going to drag them to the neurologist. So the demands on neurologists is always increasing, and having trained people who can assist in the care of these patients sounds like a great thing. So what is it that you do here in Memphis? We have pretty sophisticated stroke program. Are you involved with that?
I've recently gone back to neurosurgery, and we have an excellent acute stroke nurse practitioner who has come on board in the last couple of years. And she is actually going through the same fellowship that I went through, because there is a really big learning curve initially in neurology. As you know, they are the most complicated patients, I think, in medicine. And so just to have someone specialize in that particular aspect of care and to help the neurologist in that aspect, I think is helpful. And then it unburdens the physician from having to really spend a lot of time onboarding them. You know that you've got a good evidence base, you know how to interpret film and imaging and that kind of thing. So we have an excellent nurse practitioner right now in stroke, and she and I work very closely together on a daily basis to take care of our neuroscience patients.
So give me an example. You said you're in neurosurgery. What would your day be like as a advanced practitioner?
So I work with 5 neurosurgeons where I work, and I really am responsible for the ICU patients at consults and the ED consults. So my day will start out in the ICU. We have 5 ICUs, and now we've just recently created a neuro ICU of 16 beds. So I have quite a few patients there. So my job is really to really look out for the intensive care part of the neurosurgery patient. In coordinating, talking to everyone in terms of the intensivist, neurology, if cardiology is consulted, nephrology, and really looking at all the other things that may not necessarily be surgical, but certainly I can definitely evaluate a surgical patient. I did that yesterday, as a matter of fact. Evaluated an ER patient. That patient had a large subdural. We sent that patient to the OR after we had to give them Kcentra because they were on anticoagulant. So that is a role that is really specific. The neurosurgeons actually created that role for me. That was not a role that was created by administration. That was a role that they said, we want you to do this, and that's what I do. There's a lot of collaboration, a lot of talking between the neurosurgeons and I. But again, it's a lot of collaboration with many different specialties in order to get our patients taken care of.
So all this sounds fine, sounds pretty straightforward. So why is there a problem? What's the problem?
I think there are several issues in terms of incorporating or integrating advanced practice clinicians into neuroscience, whether it's strictly neurology or just neuroscience in general. And I think one of them, the authors pointed out very well in this article, is the lack of exposure to neurology and neurological conditions. How do you work them up? How do you do a good exam, first of all? And so the ability to really be the first person who says this person has clonus, this person has Hoffman's, lumbar spine is not their problem. That's an important thing to be able to assess. In the stroke patient, I can't localize this stroke. This may be hypertensive encephalopathy. And just knowing how those little bits of information really do help our physicians really kind of cut to a definitive diagnosis and can help with that workup. So I think part of it is just the lack of exposure to neurology has really created a problem in onboarding and creating really orientation focused programs for them. I think one of the other things too is expectations. The expectation on the part of the physician, the expectation on the part of the advanced practice clinician, and the expectation on the part of the organization in terms of the outcomes, measures that they want them to be able to really quantify and be able to achieve. And so I think it's multi-pronged problem. And the authors really did a good job of saying, we can't point out these problems without solutions. And one of the solutions is to create good expectations of what we want you to do. Are you educated and boarded to do that? What other education do you need? And be supportive as they go through that transition period.
Right. So I was very surprised when I was reading the article that there were well over 1,000, I think it was 14 or 1,500 advanced practice clinicians who were members of the American Academy of Neurology. So I didn't realize that, this was such a big deal. And obviously that number is growing, is my impression. Neurology training is long and complicated, and it's taken me about 40 years to get to the point where I'm pretty confident in my neurologic exam. So I think some neurologists are a little reluctant to accept somebody who doesn't have the extensive training, in terms of doing an initial evaluation on a patient. So that was some of, I think, the resistance I saw in the letters to the editor that you guys were concerned about. So I think properly defining the roles is key, as well as the supplementary training, like the training that you've had in stroke, so that and on the job training, there's no substitute for that, but it's not too helpful if you don't have the fundamental training to complement it. I think it's clear that both are necessary.
Absolutely. I think that certainly when I was completing my stroke fellowship, I think that it really did unburden the neurologist. So all of a sudden we could actually have a conversation, and we were very clear with really everyone. I'm not there to replace the physician. I'm there to help augment, to help make things more streamlined, and in some sense to really alert them to things that maybe they wouldn't think about. There's a lot of psychosocial issues with compliance with medications, as an example, that maybe we can identify because of our nursing background and just the different way that we might look at patients, or the different experiences we've had in our work at the bedside. So I think it's a collaborative effort that we need. I think things are being much more interdisciplinary. Many more societies are much more inclusive of advanced practice clinicians, just because of the complexity of our patients, and really the complexity of their situations. A neurologic disease is really can create a lot of psychosocial, economic issues. And so having someone help you sort that out can be helpful as well.
Oh, yes. So we see that every day at Regional One Health, where I'm division director of neurology. As we have these complex treatment plans, only to learn that the patient is homeless. So they don't even have a place to put their little, medicine bottle. I mean, and so to expect them to take it every day when they don't have a place to sleep, it's a stretch. Well, I think one easy fix, and I hope the dean is watching this program, because I think one easy fix is to improve the exposure of students to neurology. And this is also true in medicine, that a lot of general practitioners and internists have had really minimal exposure to neurology in their training, because they're learning about the heart and the lung, the kidneys, and all the other parts. But somehow neurology, it's a little harder to get into, and it's a big black box. And so it's often I don't even think it's required, as a rotation. So it's probably true for, as you point out, for nurses as well. So it wouldn't be that hard to drag more students onto the service, at least during their training. And then they can see it's like, oh, wow, that's interesting. Or, oh, wow, I don't want to have anything to do with that, so that they at least have some firsthand exposure about what it's all about. I think that might help increase the ranks a little bit and get people who are really interested in the brain and spinal cord and helping people with neurologic disorders. What do you think about that?
Well, I think that's a great idea. And I think in many of the, certainly many of the professional schools, medical school, nurse practitioner school, they're doing a lot more interdisciplinary education as well, which gives them exposure to different roles. If we look at pharmacy, for example, when I was in high school, I worked at a pharmacy and they counted pills. Pharmacists do much more than count pills these days. And so as we evolve in terms of how to take care of patients, how to really do a quality job in terms of good outcomes, I think really utilizing everyone's expertise and really letting them rise to the level of their education is really critical to all of that. I'm so fortunate that I work with all kinds of physicians and nurses, nurse practitioners who really understand that and are not threatened by that. And I think that is really key to that, is that you know what your role is and you know what you bring to the table, and that you work together for the good of that patient and that family. And I think that's really a critical piece of that.
Yeah, I'm all for it, particularly since there are definitely more patients to go around than, than there are people to take care of them. I think anybody that wants to get involved and is trained and can be helpful, please join the fray. So, Rhonda, this has been great, very enlightening for me about the role of advanced practice clinicians, and I hope to see you in the hallways. I'm sure we'll both be moving fast because there's a lot of places
That's,
to be.
that's right.
Thank you very much for joining me on the Art of Medicine.
Thank you so much for having me.
This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on the Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests, and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com